the next talk is also going to be a continuation of the same, which is going to showcase the evidence of the current topoguided treatments. This is done by Dr. Bhaskar Srinivasan from Shankar Nethralaya. He is at the forefront of both ocular corneal disorders as well as ocular surface and refractive surgery as well. So over to you, Dr.
Good afternoon, one and all, and I would like to thank the AIOS organizing committee for giving me the opportunity. Quite a bit of it has already been covered by Samresh. It's not, yeah, sorry. So when you're looking at conventional LASIK, which is still the primary way that we would treat most patients, but then if you have to customize it, you could look at asphericity-based treatments, you could look at wavefront-based treatment, you could look at topography-based treatment, or corneal aberration-based treatment. In terms of topography-based treatment, Contura is probably the most commonest platform that is being used, even though you do have with the Cirrus and in combination with the Schwein giving you a corneal aberration-guided treatment as such. When you look at the advantage of topography-guided treatment, obviously you can treat irregular corneas, you can try to improve the corneal shape, it can capture and treat the patients on their photopic pupil, but the disadvantage is it ignores the complete refractive situation as far as the eye is concerned, and when you are correcting something extra on the surface, that could change the refractive endpoint. And this was the reason that when it was initially launched, it was primarily meant to be a repair station where you could treat unhappy patients, you could treat irregular astigmatism, you could treat them to enlarge the optical zone, you could treat decentered ablations as such. It's only recently that there's been a lot more of interest in treating virgin eyes because we've started understanding what treating these additional higher order aberrations on the surface does to the refractive outcome, and then we try to tweak our manifest refraction to end getting a better result. So when you're comparing a wavefront guided with a topography guided, obviously topography guided is pupil independent. It tries to create an ideal corneal curvature, and highly irregular eyes, you might not get good wavefronts, but you might still be able to get a good topography to correct them. This has already been mentioned by Samresh, where we capture the data and feed it into the machine, and you need to treat both the clinical refraction and add on to the higher order aberrations that the surface has, which needs to be corrected to improve the quality of vision that the patient can get. So when you're looking at the virgin eyes, the FDA approval was based on certain principles that yes, you would treat it if the treatment to correct the higher order aberrations induced is removing less than 10 microns of tissue, if the difference between the topographic axis of astigmatism and the acceptance axis is less than 15 degrees, and if the difference between the magnitude of astigmatism is less than 0.5 degrees. In an ideal world, you tend to have variations, and then you're not sure whether you would want to do a topography guided treatment or you would want to do an optimized treatment, like in this example where the astigmatism magnitude is high, but the other two parameters are correct. So here is where actually when the first papers on topographic guided treatment came in, David Lin mentioned about topographic neutralization techniques, where he said you initially put the value in the modified column as 0, try to see what the laser is doing to correct the surface, identify any cylinder that it is inducing, add on the myopic treatment for the hyperopic correction that is induced by the laser, then add on the manifest refraction and adjust it. Unfortunately, at that point of time, people felt it is too complicated and it never took over. The other way of doing it at that point of time was to look at the central ablation that your optimized treatment would do, and you just tweak the refraction in your topographic modified way to kind of match the central ablation depth that an optimized treatment would give you. But these were still a lot more hit and miss kind of a situation. So now we do have certain guidelines on how we would want to do the treatment. You could either base it on manifest refraction, you could base it on what is called as a topography modified refraction, you could do a partial TMR, or you have the 4CD's analytical software to be used in certain situations. So the most important step in doing a topography guided treatment is to get good, reliable image. Garbage in, garbage out. If your topographic images are poor, no point in treating the patient with that. The next would be, if you're going to be treating it on the manifest refraction, like in this patient, the ablation was less than 10 microns difference for a zero ablation. The degrees of difference between the topographic and the acceptance was less than 15 degrees, but the amount of astigmatism was more. Here, we went ahead with just correcting the patient's acceptance astigmatism of minus 1.5, and the patient did well. If you're doing a TMR, you would actually correct the astigmatism of the patient in terms of axis, correct the astigmatism in terms of magnitude, and the difference in astigmatism between the acceptance and the topographic, you would try to add on or correct the spherical equivalent of that to the manifest refraction, and that would be your final correction. Whereas if you're doing a partial TMR, you would probably just use the axis and the magnitude of the cylindrical correction without doing the spherical equivalent. So in this patient, in this example, you have a 2 diopter cylinder. in your manifest, and you have a 3 diopter cylinder in your acceptance. So here you're going to be treating a 3 diopter cylinder, but that 1 diopter cylinder which you're treating extra, you will kind of compensate by correcting it with the spherical equivalent. The idea is to kind of make sure that your spherical equivalent of your correction that you're putting is almost the same. So here is an example where the refraction was minus 1.5, the measured was around 2.7. Ideally, we would have probably done a 2.5, but the treating surgeon was a little bit conservative, didn't want to go the full extent with the refractive cylinder and treated a 2. So the difference of 0.5 was corrected by a 0.25 adjustment in the spherical component. Another patient where you have a cylinder of minus 1.75, the topo cylinder is around 2.6, where we corrected amount 2.25, and the difference is adjusted as far as the spherical equivalent is concerned to give you a good outcome. And in this patient ended up with a 6.5 vision in both eyes. So you also have this paper, and you have a link to the Excel sheet of this in this paper, where you can feed the data in terms of a clinical refraction, your measured refraction, and it tells you whether you can go ahead with a topography guided treatment or you need to exert caution. The points for caution would be a cylindrical difference of more than 1 diopters, an axis difference more than 5, and here it is actually averaging the difference between the topo and the manifest refraction in terms of the cylinder, and it tries to maintain your spherical equivalent. So you don't have to really calculate by yourself, you just feed the data, the Excel sheet gives you the value. So here the cylinder is 1 diopter difference, and it says yes, you can probably correct it. Just a minute. And here when the difference is more, it tells you there is a warning sign, it tells you that maybe an optimized treatment would be there. These are again areas which are blurred because our understanding is improving and we are probably able to correct it better. You also have the 4Cs analytical software which takes into account the posterior corneal astigmatism also and adds on that to your treatment algorithm. So this FDA approval, Samresh had already mentioned that about 93% patients had better than 20/20 vision, and almost about 30% patients saw better uncorrected visual acuity as compared to their preoperative spectacle corrected visual acuity. And if you're looking at best spectacle corrected visual acuity post-operatively, almost 40% patients gained one line better. The quality of vision definitely makes a difference with respect to a topography guided treatment as compared to conventional treatment. So it's as good, if not better than conventional treatment, lesser visual complaints, higher number of eyes, achieving what we still label as 20/20 vision, but it's an evolving algorithm. You need to spend a little bit of time planning these procedures. However, not all candidates might be a good candidate for a topography guided treatment. Thank you.
Thank you very much for taking us through, especially the evidence of the topoguided treatment, Dr. Bhaskar.